My name's Maureen. I've been a nurse for 35 years. I work presently at University Campus in a medical ICU, and I've been there for 10 years. I'd like to address the frequency of assessment, part of that, and especially in a medical ICU, we get all types of patients. They have all different conditions, and they can deteriorate within minutes. So we do understand how difficult it is sometimes to find help. But on top of this, we are now working pretty well without secretaries. They've cut our PCAs, which are nursing assistants. They have cut ancillary staff. They expect that we're going to watch detoxing patients or psych patients one-to-one and have another patient as well. I have personally heard from some people in management as well saying that the ability to work without a secretary is, well, you nurses know how to take orders off, which now has put us into the realm of being a secretary and not a nurse. You know, we're leaving the bedside to do these other tasks. As a resource nurse, I also do resource charge nurse on occasion. I've actually needed other staff to come in, and we used to have a really great flow pool, which meant that if you needed the help was there. And I've had supervisors say, well, what is it that you want me to do? I have no one to send you, which means that giving up one of your other patients would have to go to someone who was singled already and singled for a reason. So now they're taking on the patient that should be alone with another patient as well. So that kind of puts everybody at risk. The frequent assessment, yes, we can assess patients every 4 hours without a doubt. We kind of do it every hour, basically. The other point I just really want to touch on quick is the danger of management picking the acuity tool. This is really like the wolf sitting in the hen house, if you ask me, because I have an example of what our acuity tool is right now, and they use terms like your patient is busy, your patient is sick, your patient has tasks to be done, and the only one that really deserves to be singled are patients that are on dialysis or on hypothermic protocols, which isn't true, because they're not looking at the rest of the patients within the unit. They have no idea what our responsibilities are now, and they've changed. In 35 years, our responsibilities have changed tremendously. And so, another example I'd like to give you is a supervisor who was nice enough and kind enough to say, you're a patient, staff called out, I'm going to send you someone. Would you like that extra help? And I said, thank you very much. But in return, what I got was a manager who came in extremely upset, saying you should have been able to function without that, without even knowing what the unit looked like, and proceeding to call that supervisor back and saying, you better watch out for my staff. They'll try to pull a fast one on you. So if that's the attitude that we have, that we deal with, I think money's going to be the bottom line, and it's not going to be patient safety. And that's basically what I have to say.
Thank you very much. Welcome.
Welcome. Good morning, my name is Karen Pettit, and I'm a nurse in the critical care unit at UMass Memorial Medical Center on the Memorial Hospital campus. I've been an ICU nurse for more than 12 years. My purpose today is to urge the Health Policy Commission to develop strong regulations for the new ICU law to ensure that the intent of the law is followed by hospital administration. Similar to Maureen's testimony, who works at the mothership, we have similar patient population and acuity, as well as ancillary staffing concerns. These regulations follow the intent of the law, which is to ensure that my patients who are required to be assigned to just one nurse receive that level of care, and that my assessment of my patient and that of my colleagues is followed. Unfortunately, on a daily basis, my employer is failing to provide the staff we need to ensure that our patients who need one-to-one care receive that care. On a regular daily basis, our 14-bed staffed with 7 or 8 nurses, which means at best, most, if not all patients end up being doubled, regardless of their acuity level. After reviewing your draft regulations, I can see that you include language throughout these regulations that would allow my management to continue to staff at this level because you don't make it clear as the law intends that the default assignment for any patient entering the ICU is to one-to-one based on the assessment of myself and my colleagues. The other issue I want to address is the fact that at my hospital, nearly every day when nurses leave the unit to take a patient to MRI, CAT scan, respond to a code blue or a code stroke, or even to take a lunch, other nurses on my unit are expected to care for 3 or 4 patients during that time frame. I was pleased to see that your draft regulations seem to address this, in that they state that the limit of 1 or 2 patients is for all times during the shift, and that no nurse can ever have more than 2 patients at a time. This language must remain in these regulations and cannot be weakened in any way. My patients are critically ill, and many are very unstable. I can't anticipate if my patient's going to go into heart failure or respiratory distress while I leave the floor with another patient for a procedure, or I'm going to lunch. No ICU nurse can predict when a patient's condition might change, and we shouldn't change our level of care for patients simply because our hospital won't provide enough staff to compensate for these unexpected circumstances. We need your help to make sure that my patients and those of my colleagues aren't placed in jeopardy, simply because our administration refused to abide by the law. I urge you to follow these recommendations of the M&A and to make these regulations strong enough to ensure the safety of my patients and the continuance of positive patient outcomes, and allow myself and fellow colleagues the opportunity to continue the excellent patient care we strive to maintain. Thank you.
Thank you, Karen.